So guys, welcome to the Parson series and this is Cornea part 6. I know this is quite a long time apart, but it is because of you people only that I have again come up with the Parson series because I have got countless, requests for this. So here comes the part 6 of your cornea, right? So we'll be starting with the viral infections of the cornea, the viral keratitis. Right. Now, if I talk about the viral keratitis, what are they saying? They're saying that superficial keratitis may result from a number of infections, but mostly the superficial keratitis is caused by what you called as the viral keratitis. So, as you remember also, when we discuss about the viral keratitis, viral corneal ulcers, right, basically what we always start with the SPK means superficial punctate keratitis. So basically whenever we are there with the infectious keratitis presenting in the punctate form, superficial punctate keratitis form, the first DD that comes to our mind is the viral keratitis. Okay, so what are the common viruses? Common viruses may we have herpes zoster, adenoviruses, we have chlamydia trachomatis and the inclusion conjunctivitis. And we have already discussed with the chlamydia as well as inclusion conjunctivitis. So here we will be focusing on the herpes zoster as well as adenovirus and also the herpes simplex, right? Rarely the viruses associated with the measles, vaccinia and the infectious mononucleosis and the mumps as well as the immunodeficiency disorders like Behçet syndrome, Ritter syndrome, they can also affect the cornea. And a secondary keratitis means which is following any other infection that may follow a lid infection with the viruses of molluscum contagiosum, or it can be by the warts also. So that is again important that sometimes this keratitis may be primary and sometimes it can be secondary. It can be from conjunctivitis, like whatever bacteria are able to penetrate the intact cornea, they can also cause a corneal involvement secondary to the conjunctivitis. So it can be a form of keratoconjunctivitis or it can be a form of blepharokeratitis where it is secondary to the lid infection. So secondary to the lid infection we have molluscum contagiosum and the warts, right? These viral infections may give rise to different clinical pictures. But the thing is that appearances will be same, and because they have the same appearances, you can always recognize them. Okay, so let's start with the characteristic feature. In the characteristic feature, as I told you, the most characteristic is your superficial punctate keratitis, or you can call it as the punctate epithelial erosions. So multiple superficial erosions. They are the most common manifestation of all the viral infections. So this is, important thing here. And in this condition, the cornea is showing multiple minute defects. And always remember when I am saying it is superficial. So what do you mean by superficial? Superficial means that they are in the epithelium, which can be stained with the help of a fluorescein stain. So if you remember the stain of this, it is the fluorescein stain which is appearing green, because what filter we are using is the cobalt blue filter. Now, this is frequently acute in onset, and what kind of conjunctivitis it is? It is acute conjunctivitis, right? There is considerable pain, photophobia, and the lacrimation. So, associated symptoms, whenever, epithelium of the cornea is involved, we will have pain, we will have photophobia, we will have watering. All these features are of acute keratitis. As a rule, infection is characterized by the recurrences. But when the fresh erosions are coming in crops after the original ones have gone. So one more important thing. See, two important things that you already know about viral keratitis. One is your keratic precipitates that we already know. Second thing is your decreased corneal sensations. We have decreased corneal sensations that also we know. Third important thing is superficial punctate keratitis. Fourth important thing is the watery discharge. Now, these things will again help you in solving the clinical case scenarios. The fifth important thing is whenever we have viral keratitis, we have maximum risk of recurrences. So why we are having the recurrences? We are having the recurrences because after the primary lesion is getting healed, these viruses are remaining in the Gasserian ganglions, in the trigeminal ganglion. So from there are always chances of recurrences. That is why we are getting recurrences here. If these recurrences persist for a considerable time, superficial vessels may invade the cornea. Now, if there is recurrences, what can happen is the vascularization. And when there is vascularization, obviously it can go to the deeper level. So from here the vascularization is appearing, we can have the superficial vessels. However, a completely non-specific lesion of this type may be caused by other agents also, like the toxin of the staphylococci. So, most of the time this kind of picture is actually viral keratitis, but this does not mean that it cannot be bacteria. It can be a toxin of staph, which can be presenting with the blepharitis also and conjunctivitis also, sometimes a chemical irritant. So this will actually come under the differential diagnosis. They will come under the differential diagnosis, in which we have the toxin of staphylococci, we can have the chemical irritants associated with the general febrile disturbance. This is a very well established manifestation of an infection, or the adenoviruses. Then it can be adenoviruses, and adenovirus is typically a viral keratitis where you have a clinical prodrome. So if they are giving you a clinical prodrome also, systemic features also, lymphadenopathy also, you have to first think about the adenovirus. Treatment, if I talk about the treatment, it is simply lubricants. We have broad spectrum non-epitheliotoxic antibiotic drugs like chloramphenicol to prevent the secondary bacterial infection, and the important thing is steroids should not be used. So I think this is even more important than the treatment, that steroids should not be used, because steroids are always a double-edged sword. Either we are using them, they are indicated strongly, or they are strongly contraindicated. They have to be avoided. So that is important thing. Now, if I talk about the punctate epithelial keratitis, so specifically now we are coming to superficial punctate keratitis. It is usually a viral infection of both the eyes, which runs a course of the months or sometimes even years. And this can go into the deeper layers of the corneal epithelium. It may go into the Bowman's membrane and even the superficial layers of the stroma. So this superficial punctate keratitis is not just limited to epithelium. So this is the main difference when I'm using the word just the erosions. Erosions, E for E, you can remember erosions are only in epithelium. But once I use the word superficial punctate keratitis, that means in the superficial layers of the cornea. When I'm saying it is the superficial layers of the cornea, it is the epithelium, it is the Bowman's membrane, and the superficial part of the stroma also. Superficial part of the stroma you can use like we are using in the keratoplasty. You can use it for less than half of the stroma. If they are using less than half of the stroma, then we can say it is the superficial part of the stroma. The epithelial opacities, they are appearing as superficial, slightly raised gray dots scattered over the central area of the cornea, which do not readily stain with the fluorescein, but now the staining is taking place with the rose Bengal stain. So if you remember what we talked about the dendritic keratitis in cases of herpes simplex also, that kind of keratitis is dendritiform, arborizing tree-like pattern is there, where you have the knobs and you have a float. So basically these knobs are staining with the rose Bengal stain. Knobs are staining with the rose Bengal. While if you look at this floor, F for floor and F for fluorescein, floor and fluorescein. So floor is stained with the fluorescein dye, while the knobs are stained with the rose Bengal dye. A combination of epithelial as well as the subepithelial punctate lesions is also common in occurrence. So when you are having that combined, then it can be called as epidemic keratoconjunctivitis, pharyngoconjunctival fever. I told you that in cases of the adenovirus, you have got two kind of presentations. One presentation is in the form of epidemics, like which is spreading in the communities, societies, schools, colleges, and another is the typical prodrome of the viral fever, where you have pharyngoconjunctival fever. Pharyngo is pharyngitis. Pharyngitis is a sore throat. Then we have conjunctival, that is conjunctivitis, where you have watering, and then you have the fever also. So that is a typical viral fever. You have a sore throat also, you have a lot of watering, and along with that you have fever. So adenovirus can present in both, right? Now if you look at the principles of treatment of these condition is actually symptomatic. You have to use the lubricating drops. If I talk about the steroids, they have a suppressive effect, but the lesions reoccur on the withdrawal of the steroids. So if you are using the steroids, you have to be very, very cautious, right? Plus, we have to be cautious about the steroid-induced glaucoma. As I always say, you have to remember about GTCS. What was this GTCS? If you remember, topical steroids can cause glaucoma, systemic steroids can cause cataract. So you have to be very, very cautious about the side effects of these steroids. And along with this, we can have the superficial infections also, bacterial infections, fungal infections. There is always a risk. If I talk about herpes simplex ocular involvement has varied. It is taking place in all forms like blepharitis, also conjunctivitis, keratitis, iridocyclitis. So viral infections are, widespread in that matter that they are causing the involvement of eyelids also, conjunctiva also, cornea also, as well as iris and ciliary body. So everywhere they can cause the inflammation. Now, if I talk about the involvement of this cornea, so this involvement can be the epithelial keratitis also, it can be stromal keratitis and endothelial keratitis. Now, what were the 6 layers of the cornea? It was the A, then B, C, pre-D, D and E. So it was anterior epithelium, then B for Bowman's membrane, C for connective tissue stroma, pre for predesmens membrane, then desmens membrane, and then endothelium. So basically, if you see, it is causing the involvement of this epithelium also, then stroma also, and then the endothelium also. In epithelium, what is they are causing? They are causing the dendritic keratitis. So whenever we have tree-like arborizing pattern, dendritic keratitis, you have to give the 3% acyclovir. What you not have to give is the steroids, because if you are giving the steroids, it can lead to geographical ulcer. There can be enlargement called as the geographical ulcer. So absolutely contraindicated are your steroids. Second is your stromal keratitis. Stromal keratitis is your disciform keratitis, where you are getting the disc-like areas, coin-like areas, and ultimately endothelial keratitis, where you are having the formation of bulli also, or you can have the involvement of your metabolically active layer. Now, what happens whenever this herpes is spreading? It has a very, very widespread distribution. It can be grown in tissue culture also, elementary bodies you can find. And it has been seen, there is some evidence that it also has a antigenic properties. So, though they say that it has antigenic properties, now if I say that it has an antigen property, it should be leading to antibody formation, and therefore it should have a lifelong immunity. But actually this is not happening, and immunity does not develop after an attack, and a person becomes a carrier. Now, I think that is the most dangerous thing, that the person is not developing himself, but he becomes a carrier. So overall, he is becoming infective. Now, what are the modes of infection? If you see, the modes of infection are the lips, nose, cornea, and this is for the 1. If I talk about the 2, then obviously the genitals. Basically, herpes simplex 2 is spreading through the genitals. Recurrence takes place particularly in association with some intercurrent diseases. It can be cold, pneumonia, relapse of malaria, or exposure to sunlight. So basically, say that whenever there is some opportunistic conditions, we can have relapses. Relapses are really, really common in cases of viral, especially the herpes infection. Now, though it is herpes simplex in name, it is simple in condition, but it is not as simple as that, because, relapses are really common, and especially with the very, very common diseases like common cold, pneumonia, malaria, and sunlight. So you can see we are getting these kind of vesicles. And as I always say, all these pictures which are given in the Parsons are really, really important, because many times they are giving as it is, the same pictures, replicas they are giving. So it's really good if you look at these pictures. We have the seropurulent vesicles due to the herpes simplex. Now coming to the clinical manifestations. So we have clinical manifestations in the form of primary herpes also, and in the form of the recurrent herpes also. Now the primary herpes is seen in the children, and it can present as a severe follicular keratoconjunctivitis with a vesicular blepharitis. So basically primary herpes is presenting with the blepharitis also, conjunctivitis also. Conjunctivitis is the form of your follicular conjunctivitis along with the involvement of cornea. But if you see the recurrent herpes, here it is more of corneal lesion, and therefore it's going into the deeper areas. Now, how it is starting? It is starting just with the epithelial keratitis. In the epithelium, how it is starting? Basically, 2 things are there in the epithelium. One is your SPK, and second is your dendritic keratitis. So any of one can take place. One is your SPK, another is your dendritic keratitis. So one is your SPK, this one is there, followed by the erosions which are accompanied by, now because there are erosions, due to the erosions on the cornea, we can have irritation, we can have watering, we can have blepharospasm, but the thing is that because they are superficial, they are healing rapidly and they are causing no opacity. And I think that is a boon, because whenever it is causing opacity, that can lead to diminution of vision. Usually, however, fresh crops appear and the condition may prove very obstinate. In all cases, the cornea is relatively insensitive. So decreased corneal sensation is a typical feature in cases of viral keratitis. That is also there. Now, in the severe forms, when it is causing dendritic ulcers, you cannot forget dendritic ulcers in cases of viral keratitis. That is unavoidable. Initially superficial, the infiltrates are developing and spreading in all the directions as a gray stria. They increase in length. They are ascending the lateral branches and knobbed at the end. So a dendritic figure, tree-like arborizing pattern is formed. This resembles no other condition and it is pathognomic. It's very, very important. Means you cannot forget herpes dendritic keratitis, right? So the surface over the infiltrates, it is breaking down and a irritating ulcer is produced, persisting with the exacerbations. But the thing is, it is not extending in the depth. It is spreading horizontally only in the epithelium. The ulcer stains with, so I told you it is staining with the fluorescein and the margin with the rose bengal. F for fluor and F for fluorescein and knobs with the rose bengal stain. Fresh spots are continually being formed and the disease frequently reoccurs. Alternatively, a large ulcer may also be formed. Okay. So look at the pictures here. You have got a fluorescein stained ulcer keratitis and you can see here they have stained the fluorescein stained ulcer. They have stained it with this. Then second, you can see dendritic ulcer that is stained with the fluorescein again in a cobalt blue filter. And third is where they have stained it with the rose bengal dye. So both of these stains we are using. In the stromal keratitis, as I told you, stroma mein they are coming up with the disky form keratitis. We have coin-shaped areas. And this is an immunological reaction which is resembling the Arthur's reaction. This is a direct question which can be asked. And finally, it can also present with the endothelitis. Endothelitis means what is happening? The inflammation is limited to the endothelium. We can have keratic precipitates. And because it is affecting the most vital layer where the sodium potassium pump is there, so it can result in corneal edema as well as the Descemet's folds. And iritis is invariably associated with the severe herpetic keratitis. So this is actually, severe form because it is affecting the endothelium. Endothelium is a metabolically active layer of the cornea. It's the most vital layer of the cornea. So can be edema. And edema can lead to the Descemet's folds. We can have even a hypopyon. The herpes infection virus have been isolated from the aqueous in such cases. Even you can isolate the virus from the aqueous humor. Diagnostic test may, what can you do? We can have the immunofluorescence and the culture of the epithelial scrapings or the tissue biopsies that can also be there. Now finally the treatment. Now the treatment of this herpes depends upon the nature of the ocular involvement and it requires a judicious use of topical and systemic antivirals, topical steroids as well as a supportive therapy as with the lubricants and cycloplegic. See that I told you before also that whenever we have a case of corneal ulcer or keratitis, there are two treatments. One is a causative treatment, another is supportive treatment. Causative treatment will obviously vary, but the supportive treatment will remain same with the lubricants and the cycloplegic. So whatever is the cause, you have to treat it. Steroids are always a double-edged sword. You have to see whether you have to give here or whether you have to avoid here. So topical antivirals, we have various commercially available antivirals present. We have 5% idoxuridine. We have got 1% trifluridine. We have got 3% acyclovir. That is the most commonly used one. Then we can also use the 3% vitebrine eye ointment and oral acyclovir. Oral acyclovir we are using for the herpes zoster, not for the herpes simplex. Then coming to the epithelial keratitis is responding well to the topical antivirals which are prescribed along with the topical antibiotics. Why topical antibiotics in cases? Because secondary bacterial infections are quite common. Lubricants for the supportive treatment to relieve the discomfort, as well as the cycloplegics. Debridement of the edges of the dendritic ulcer with a moistened fine cotton tipped applicator. You can do the debridement of the edges also. 85% of the initial dendritic ulcers are treated with the idozuridine 5 times a day, cured within 2 weeks. Trifluridine 1% drops 4 times a day, or what we are using is a 3% acyclovir 5 times a day. That is the most commonly used treatment, and that is treating in 95% of the patients are being treated by this. It is uniformly accepted and topical steroids are contraindicated in the presence of the active viral infection. So this is again an important thing. Topical steroids are contraindicated because it can hasten the formation of geographical ulcer. Next is your stromal keratitis. Stromal keratitis, including the disciform keratitis, endothelitis, and the iridocyclitis, they are treated with a combination of topical steroids and topical antivirals and cycloplegics. So this is a very interesting case here, that in the first phase of the herpes simplex, where we have the disciform, this one dendritic keratitis, the steroids are contraindicated, while in the second one disciform, they have to be given because stromal keratitis can't be treated without the steroids. Certain aspects of treatment have been clearer after the results of multicentric herpetic eye disease study. So remember the name of this study here. We have herpetic eye disease study. In the absence of accompanying herpes simplex viral epithelial keratitis, stromal keratitis improves more rapidly when corticosteroid eye drops are used along with the topical antiviral agents. So if you are not having the epithelial component, basically you have to give the topical steroids. Oral isoclavir does not seem to prevent the occurrence of the iridocyclitis or stromal keratitis. So it is not giving any extra benefit. So as I told you, we are not using oral acyclovir in every case. Oral acyclovir is appearing to provide no extra benefit over the topical steroids and trifluridine used in the treatment of stromal keratitis. However, oral may be added to a regimen of a topical and corticosteroids. If there is a requirement, we can add, but however, we have not seen much extra added advantage of using it. A low dose acyclovir prescribed for long periods reduces the rate of recurrence. So obviously recurrence is a problem. So it is better that you consider this from the initial phase only, that what should be given in order to reduce the recurrence. So for this, what we can use is the low dose oral acyclovir, which is prescribed for the longer periods. That is good for preventing the recurrences. Then we have penetrating keratoplasty. Penetrating keratoplasty we can use in the cases of the herpetic scarring. Eyes with extensive vascularization will have a rejection of a graft, and the recurrence of the active herpetic infection in the transplant is often a problem. This was actually a frequent question previously in the AIMS also, that which of the following infections is most common in the graft. So whenever we are doing the graft, viral interstitial keratitis is very, very common. Viral interstitial keratitis. Viral interstitial keratitis is very, very common in the grafts. Then coming to the herpes zoster. Herpes zoster is also caused by the same virus which is caused by the which is causing the chickenpox. That is varicella zoster virus. Now varicella zoster virus, when it is causing a chickenpox, that actually gives you the lifelong immunity. It is not recurring. But the thing is that this virus, if it is there in the body, it can actually lead to herpes zoster ophthalmicus. So that could be there. Mode of infection. After an infection with the chickenpox, the virus is actually lying dormant. So basically it lies dormant, and those people who have got a depressed immunity, they can actually cause the picture of this herpes zoster. So you don't think yourself to be safe from, this herpes zoster ophthalmicus. If you had a case, or if you had suffered from the chickenpox, and at times you have the depressed immunity. In zoster ophthalmicus, the chief focus is the Gasserian ganglion. From there, it is going to the ophthalmic division of the trigeminal nerve, and from there, from the ophthalmic division of the trigeminal nerve, it is going through all the three divisions. That is, it is going to the frontal division, then it is going to the lacrimal division, and then finally it is going to the nasociliary division. So first of all, we will get the eruptions on the forehead, frontal part. Frontal, that is your forehead may you will going to get. Then you are going to get the eye involvement, and nasociliary say you are going to get the tip of the nose. Tip and the side of the nose you are going to get. So this is the area. So strict distribution on one side of the forehead you are having the involvement of this frontal area, then lacrimal area, then the tip of the nose and the side of the nose, and this leads to a Hutchinson rule because this will always go in this order. So if you are getting the eruptions on the tip of the nose or the side of the nose, that shows that first there is involvement of lacrimal involvement, and therefore the chances of ocular complications are really high. Okay, so this is again very important. The images, strict distribution on one side of the forehead is really important. And then you can see the keratouveitis, pneumokeratitis. Like in cases of herpes simplex, what is important is the dendritic keratitis. Similarly, in cases of herpes zoster, the characteristic lesion is the coin-shaped areas. That is called as a pneumokeratitis. Now, that does not mean that we cannot have dendritic keratitis in herpes zoster. Yes, we can have the pseudo-dendritic keratitis. Pseudo-dendritic keratitis means it will not have knobs. It will just have the dendritic pattern but no knobs. Okay. Alright, so we have involvement of the supraorbital, supratrochlear, infratrochlear branches, and it is nearly always unilateral, does not cross the midline. So I told you that there is a strict distribution on one side of the forehead. If you look at the symptoms, this is, typical prodrome. First is your general features, then your cutaneous features, and then we have ocular features. So in the general features, we have fever and malaise, then we have the eruptions. Eruptions are, along the course of the ophthalmic division of the nerve. So we have along the frontal division, lacrimal division, and nasociliary involvement. So first there is pain. So even before the appearance of these eruptions, we know that there has to be, pain in that region, and whatever area is showing me pain, only those areas will show the eruptions also. The pain sometimes ceases after the outbreak of the eruptions, but it may continue for even months or years. And this is, very pathetic condition. The pain is very severe, and patient continues to have pain even years, even 10 years after that also. The skin of the lids and the other areas, they become red, edematous, so we may get confused with the erysipelas, so that may act as a DD. But because, we have the characteristic distribution, we have strict distribution on one side of the forehead, so most of the times you will get to know. Vesicles you can have the suppuration, we can have bleeding, we can have pitted scars, all these things are there. And even, afterwards we can have the anesthesia of that skin. So basically when we have the eruption of these cutaneous eruptions, first the pain will increase, gradually it will settle down, and it can even lead to the anesthesia of that skin. Ocular complications arise as the eruption is subsiding but may be overlooked during the acute stage. Ocular lesions are associated with the nasociliary branch of the trigeminal nerve, that is your Hutchinson rule. Hutchinson's rule says that whenever we have involvement of tip or side of the nose, ocular complications are more likely because, first is involvement of frontal division, then lacrimal division, and then the nasociliary division. Then we come to the signs. The corneal signs, as I told you, most characteristic is your pneumokeratitis, as we were having the dendritic keratitis in the herpes simplex. Here we are having the coin-shaped areas, that is your pneumokeratitis. Sometimes the infiltration spreads and diffuses into the stroma, then it can be associated with the iridocyclitis, and cornea insensitivity has to be there. Decreased corneal sensations is a typical sign that you are getting in both the viral keratitis. Similar nodules leaving the gray areas may appear on the sclera also. We can have sectoral atrophy that appearing on the iris also. So basically it is more severe and more diffuse, spreading onto more organs. The intraocular pressure is sometimes diminished in the early stage, but we can have afterwards secondary glaucoma because of the iridocyclitis. Ocular lesions and corneal anesthesia are very obdurate and often persist, right? Then there can be associated paralysis of motor cranial nerves. Motor cranial nerves we can have third nerve, we can have fourth nerve and sixth nerve, seventh nerve, and even the sensory nerves, fifth nerve also. This will be called as the neurotrophic. When the sensory nerve is involved, this is called as neurotrophic. When this seventh nerve is involved, then it is called as the neuroparalytic. Paralytic means the motor supply. Motor supply of the eye is orbicularis oculi muscle, which is supplied by the facial nerve, right? So facial palsy is dangerous because it is causing the exposure of the cornea. So this neuroparalytic can also lead to exposure keratitis. It can also lead to exposure keratitis because due to the palsy of orbicularis oculi, the person is not able to close the eyes, and that can lead to exposure keratitis. Acute retinal necrosis can also take place in some patients. Time interval between skin infection and retinal necrosis can be from 5 days to 3 months, and finally it can also cause the optic neuritis. So wide variety of complications and more systemic found in herpes zoster. Coming to the treatment, we can have systemic as well as topical treatment. I told you Simplex is simple. There I require only the topical treatment, but in cases of herpes zoster, we require the systemic treatment. So we have to give tablet acyclovir 800 milligram 5 times a day. That is recommended, and that can accelerate the healing time by 50%. Drug should be administered as early as possible, no later than 4 days after the onset of rash. Pain during the first 4 weeks is usually severe. For that, you have to give oral analgesics. If it is not effective, then even we can go for the opioids. That is the most effective painkillers. Systemic steroids are recommended in cases of progressive proptosis. So if you have a lot of proptosis, give the systemic steroids, and initial doses 60 milligram per day. Then you can even try the non-steroidal if you don't feel like using the steroids or if there is some contraindication. Topical agents we have the topical antivirals, we have antibiotic ointments for these eruptions. In the eye itself, topical antivirals are not indicated, but antibiotic ointment is useful in order to prevent the secondary bacterial infections. Now, when the herpetic infection gives rise to scleritis, we can have sclerosing keratitis. So in this case, obviously you require steroids. So due to the involvement of the sclera, we have to use the dexamethasone 0.1% eye drops. This tends to reduce the ischemia as well as the fibrotic scarring. Then we have the artificial tears. Artificial tears are required following an attack of herpes zoster. Whenever there is an attack of herpes zoster, we have the dryness, we have dry spots on the cornea, then we have to give the artificial tears. Then we have neurotrophic ulcers. Neurotrophic मैंने बताया, trophic is sensory. So whenever we have involvement of the sensory nerve supply and we have neurotrophic ulcers, we can treat them with the tarsorrhaphy of the lateral half of the eyelid. So we can do the suturing of the lateral half of the eyelid so that the dryness does not come due to the involvement of sensory supply. Neglected disciform keratitis and sclerokeratitis often give rise to dense scarring and the lipoid deposits in the central cornea. Such patients may require penetrating corneal grafting if the cornea is not too much vascularized, because whenever cornea has too much of vascularization, graft rejections are very common. So this was about the viral keratitis. I think a very important topic, because viral keratitis is again a topic which is frequently touched upon. They are asking you questions also, and both in the university exams as well as your NEET entrance exam, NEET PG entrance examination. And plus, whenever you have to solve a question related to keratitis, I think the sound understanding of all the 4 types of ulcers is required. Only then you are able to differentiate between bacterial, viral, fungal and parasitic. So I hope you have understood and you have got an insight of the viral infections. Be prepared, read this, and be ready for the parasitic infections in the next upcoming session. Thank you and happy ophthalmology.